It's time for DocTalk Radio, brought to you by Gilbert Hospital and Florence and Anthem Hospitals. I'm Dr. Ann Borik, board certified in internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being. Welcome to DocTalk Radio, sponsored by Gilbert Hospital and Florence Hospital at Anthem. Joe, how you doing today?
I'm doing good, Dr. Borik. How about yourself?
Good, good. You know, we have a really, really great show in store today. We're fortunate enough to have a heart surgeon in the studio. And I want to introduce our listeners to Dr. Smolens.
Hi, thanks for having me.
Thank you. Thank you for being here. You know, for those of you listening, this is an opportunity, really to connect. I don't know, but not too often do we get an opportunity to talk directly to, a heart surgeon and ask questions about women's health, heart health. So I'm excited that you're here, so we can kind of, dialogue and talk about that. So
thank you, and I'm glad to be here. Thanks for having me.
You know, Dr. Smolens is a cardiovascular surgeon. She's the medical director of the Heart Center, the Women's Heart Center at Banner Heart Hospital.
Correct.
As well as the president of the volunteer board for the American Heart Association of the Greater Phoenix area. So call in 480-745-1033, get your questions kind of ready. But why don't you just tell us a little bit about your background?
So I am a cardiothoracic surgeon. That means I operate on the heart, very similar to what a cardiologist does, but I actually do bypass surgery and valve replacements. So I spend my day in the operating room as opposed to seeing patients in the office typically. Mm-hmm. My background is such that I lost my dad to a heart attack when I was 6, and I can only say it obviously influenced my career path.
Wow.
And so one of the things that I always wanted to do growing up was give back. And so I try to do talk shows like this and get out there and be active in the American Heart Association to help educate people so that other kids out there don't have to go through what I did when I was a little kid.
That's awesome. That really, really is. And that's what I get, as just in talking to, and I hear that that you're really interested in educating people. And I think you have that passion, and that's really, really awesome, because you don't see too much of that,
Thanks. And I do have that passion. And, I think anytime somebody's really passionate about something, it truly comes from the heart, not to make a pun out of this whole thing, but it really has come from my own heart, losing my dad at a young age. And then my mom actually had vascular disease and died of complications from a stroke. So it's really affected our family tremendously. And my brother and I both have taken it upon ourselves to be active in the American Heart Association and get out there and help and make a difference.
Wow. Let's talk about women's heart disease, because, as female physicians, I think that would be a really great place to start, just to kind of outline, how is women's heart disease different than men's, that kind of thing.
It's really, you and I were talking about this before, but to kind of elaborate, I think, about 10, 15 years ago, women really became, we became aware of the differences of women's heart disease from men. I think a lot of times women got lumped in with men in terms of heart disease, especially the early on studies that were done never even included women in the studies, so it was hard to even decipher what was pertinent to women versus men. And it was in the 90s that the Women's Health Initiative did a study looking at giving estrogen replacement and progesterone and estrogen replacement to women, thinking that that was protective, because we always thought women's heart disease developed postmenopausal. And actually the studies were aborted early because the results actually showed very condemning evidence that giving women exogenous estrogen or estrogen by mouth, by pill, actually hurt them. They had a much higher incidence of heart disease and heart death and vascular-related deaths. And from those studies, a lot of different women became involved in research and investigation to look at the differences between women's heart disease and men's heart disease. And actually out of those studies came the American Heart Association's Go Red for Women's movement, which is really their whole arm involved in research for women's heart disease as being different than men.
That's really interesting. When you talk about the difference between women's heart disease and men's heart disease, is it that there's decreased blood flow, or kind of elaborate on that?
Women present differently than men, and there are a lot of different theories behind why that is. Some of it more recent research than others. But there were all these myths that came about that that heart disease was a man's disease, that women didn't get affected until they were elderly. And as we've started looking at this, we've really dispelled those myths, and they really are myths. And in particular, that breast cancer was a greater threat to women. A lot of women believe that to be true. And that's completely false. Heart disease is the #1 killer of women. And so then you kind of, in medicine, you do things a little backwards. You look at people, you look at how they do, and then you start working your way backwards. And so people are trying to figure out why there is the differences. And women tend to be smaller. Women tend to present later in life with disease. They have a higher incidence of diabetes and obesity and hypertension or high blood pressure. They all roll together. And so then for a while, a lot of people believed, well, it's women's blood vessels are smaller. And that's something I encounter in the operating room. Right. In fact, they are a bit tinier, but does that really affect the outcome of women doing worse than men from conventional therapies of angioplasty, stents, and bypass surgery? And that's probably not the whole picture. Fairly recently, an article came out within the last 2-3 years demonstrating that women don't have discrete little blockages of their vessels. They actually have disease downstream in the vessels that we can't even see with conventional modalities like angiography or X-ray imaging. Wow. And so, it's like simple physics. If you remember physics from high school, for something to flow down a pipe, you have to have good inflow, an open pipe, and then a path at the end of this that's got open, no resistance for blood to flow through. And women have a very high resistance distal bed, so there's obstruction to flow, so bypasses or angioplasties or stents are not going to last as long because you can open up the pipe, but if the pipe isn't flowing into something open, it's never going to work. And that's probably more of a theory as to why women's heart disease is different than men. You'll get women who come in who have slight atypical signs and symptoms of a heart attack. The lab tests that we look at go up a little bit, but their EKG doesn't change. They get taken to the cardiac catheterization lab where we put dye in their arteries, and we don't see the typical blockages. And these women were the women that got kind of patted on the back by their docs and said, oh, honey, you're going to be fine. And in fact, they really did have a heart attack. In fact, they have disease downstream that you can't identify. And it's much more difficult to try to treat that disease when we can't even really get a good handle on it.
Right, and it's those people who do worse, actually.
Oh, they do infinitely worse. Right. Because, when we look at heart function, we look at systolic and diastolic function. And simplistically, it's the way the heart squeezes and the way the heart relaxes. And those numbers are numbers that you're told when you even get your blood pressure checked. But women can actually have normal squeeze of their heart, but very abnormal relaxation. And some people, myself included, believe that abnormal relaxation is related to this microvascular disease that we can't even put a handle on. And that can be much more deleterious to somebody's outcome than bad contractile function. Because we have all sorts of tools and medicines available to help the heart squeeze better. We don't for relaxation.
That's interesting. It's kind of like the silence, between the notes, if you will. It's what we don't hear that can be a problem.
Absolutely.
And then let's talk about smoking for a moment, because I think, in women who smoke, that's got to be like the worst combination, to be a female and then smoke on top of it with a family history and cholesterol.
I was trying to think of a funny way to say, let's not talk about smoking, because I think it is probably one of the single worst things that you can do to yourself. There has been never ever in my recollection an article published that says smoking's beneficial. I think everybody knows that it causes lung cancer. It's associated with lung disease. I don't think people are as familiar as its deleterious effects to a blood vessel. But the way I tell people to look at it, it's like taking a can of gasoline and throwing it on a fire.
Absolutely.
And it's really bad for you. There is no benefit to smoking. And actually, some of the data in our literature, the surgical world's literature, shows that bypass grafts, when we open up and we reroute blood around areas that block, should last 15 to 20 years for most patients. If you smoke, those bypasses can be limited to 18 months to 2 years.
Wow, that's amazing.
That's a dramatic change and dramatic difference. And so a lot of times, instead of beating my own patients over the head, I go, listen, I'm going to tell you one statistic. That's it. You can make the choice.
Very good. I think that's what's needed. For those listening, again, 480-745-1033. I know we have some calls coming in. Joe, I don't know if you want to get to the calls. But before that, we had some calls before the show, and I just want to kind of shout out. Linda from Birmingham, Alabama, called in and said she loves the show. So, Linda, thank you for being there. Monty and Jenna from Moreno Valley, California, it's their 30th anniversary, so we want to wish them a happy anniversary. And Ronald Perry from Clarksville, New Jersey, called in and again said, so, we have this group of people who is following DocTalk, and so it's kind of exciting.
That's very cool. I like that.
It's neat. Joe, what do you have there?
Josephine from Yonkers, New York. She said, my mother, grandmother, and great-grandmother have all had heart disease. She's 24 years old and already has high blood pressure. She wants to know, is there something she can do to give herself a better chance of living? She doesn't smoke. She only drinks socially and is about 15 pounds overweight. She's talking about supplements, any daily pills, or anything she can do to increase her chance of survival.
Well, Josephine, hi, and I'm actually from White Plains, New York, so Yonkers is very cool. But here's my advice to you. At 24, if you already have high blood pressure, you need that aggressively treated, either with lifestyle modification, which means losing that 15 extra pounds, and exercise. And if that doesn't treat it, you may even need medication. High blood pressure and heart disease go hand in hand, and so you need to be very cautious. Additionally, if you're only 15 pounds overweight now, as you get older, it actually becomes a larger weight span that you're overweight. And obesity and diabetes run hand in hand with high blood pressure, and those three things together really are a recipe for heart disease. I don't know if your mom and your grandmother had those issues, obesity or diabetes or high blood pressure, but you need to monitor it. There's really no magic bullet to fix this. The biggest issues are lifestyle modification. What I mean by that is exercise. The American Heart Association recommends even vigorous walking, 30 minutes, 5 to 7 days a week, and I think we can all find 30 minutes in our day to do that. Even though it's challenging, some days you can do it. If you smoke, don't smoke. I can't remember if we said that you smoked or not. And then in terms of weight loss, if you actually increase your exercise and decrease your caloric intake by a small amount, you'll lose that weight gradually. You don't want to go on a radical diet. You want to modify your life so that you're making a change that you're going to implement for the rest of your life, not a diet you're going to be on for 2 months.
That's good. Just a couple of things. Passive smoke as well. To try to, keep yourself out of being in spaces where there's a lot of other people smoking, because certainly that can affect. What about fish oil? Are you an advocate of anything like that? Or,
I am. As a surgeon, it's actually kind of funny because fish oil is great. It's a natural blood thinner, but I always cringe when my patients tell me they're on it and I have to operate on them because I have no way of reversing it. But it's a fantastic thing to take, and I honestly can't remember the brand names, but some of the health food stores now have. I think it's I'm sorry, I'm blanking on that.
Okay.
But there's a type of fish oil that doesn't have the oily aftertaste, so a lot of patients are saying it's a lot better, and it's available in some of the natural food stores. The older fish oil that we had available, a lot of patients complained that it really led to indigestion and kind of regurgitation of a fishy taste, so it was not very appealing to take. Right. And they have better ways of taking it now.
When you're saying that you cringe when you go to operate and someone was on fish oil, what would be the reason for that? Is that
it's a natural blood thinner, and we have no way of reversing it. And when we operate, one of the things we bank on is their bleeding to subside at the end of surgery.
Gotcha.
So we really don't like operating on people that don't stop bleeding.
I was thinking maybe it smelled different or something.
Yeah, no.
A couple of things out there from the chat. First of all, we have Dr. Smolens. Dr. Smolens rocks. Thank you out there from Red Mountain. And then we've got a question that says, let's see, my friend has cholesterol that reads around 300. He works out very hard and eats very healthy. Doctors say he has the blood flow of a 20-year-old. He's 51. Is that considered a high risk given the facts?
Well, we need a little more information, and you may not even have it. Cholesterol is a total number. There's the components of good cholesterol and bad cholesterol, and your friend who has a cholesterol of 300 may have a significantly higher proportion of good cholesterol, and then in fact he's doing okay. But if his bad cholesterol numbers are greater than 100 or 120, depending upon his own risk factor profile, if he's eating well already, he's not overweight, and he's exercising, he's doing pretty much everything he can do, he may need a medication to help bring that cholesterol down.
Right, so it's the LDL, the lethal, which is the number that if you don't want to be high, and the HDL, which is the number that is the good cholesterol. You want that to be high. So
right, and exercise actually does raise that. And so when you start an exercise routine, you'll actually notice your own total cholesterol may go up because your good cholesterol is actually going up and your bad cholesterol is going down. But if you exercise really vigorously, the higher the HDL, the good cholesterol, could actually go up even higher.
Yeah, I just experienced that myself. Just had blood work done and my HDL is higher. So that's good.
That's protective. That's actually a good thing.
Mm-hmm. Joe, do you have any other questions there? We can continue to talk. Let's talk about the indications for heart surgery versus stenting, and because I know there's a lot of talk about.
There's a lot of talk about that, as always, and so let's kind of backtrack a little bit for some of the people out there listening. What's the difference between the two modalities of treatment? First of all, I always use the analogy for my patients, but I think it's a good one, and talk about blocked pipes in your house. And so you have two ways to approach a blocked pipe. You can clean it out from the inside, roto-rooter it, and that's the equivalent of an angioplasty or stent. The doctors go in through the blood vessel, open it up with a balloon, and then put a drug-eluting or a mesh stent in the vessel to keep it open. That works if there's a discrete, isolated area of blockage or less than 2 vessels blocked. The data has shown in diabetics and people with multiple vessels blocked, they actually do better long-term with bypass surgery. So what's that analogy? It's blocked pipes again, but you have to lay down new piping. And so what we use for new piping is we use arteries from underneath the breastbone. Those are called the internal mammary arteries. Typically the one on the left side is used preferentially. We can use arteries from the arm called the radial artery, or very commonly we use vein from the leg called the saphenous vein, and that acts as new piping. And we reroute the blood around the areas that are blocked. So when is one superior to the other? When is one used preferentially? Again, it's one of these decisions we make based on each individual patient, but clear data shows that in people with multiple vessels blocked, or in what we call the left main artery blocked, bypass surgery has a better long-term result, especially in a diabetic patient or in a patient whose heart pumping function, their squeeze function is low. They do better with bypasses. People with a isolated single vessel that's blocked, or in the midst of an acute heart attack, they can use angioplasties and stents to bail us out of the acute situation, let them recover, and they may even need surgery down the road. And there are patients that actually benefit from what we call hybrid approaches. Just like a hybrid car combines gas and electric, we use stents and angioplasty in combination with bypass surgery in some patients to gain the best bang for our buck.
Very good. So walk us through, if the pre-op preparation, if you have a patient, I mean, what do we want to make sure that the outcome is the best that we possibly can get, in assessing?
For any surgery, as a surgeon, I'll tell you, the best shape you're in going into it is going to determine how well you come out of it. Most bypass surgery, not necessarily valve surgery, comes as a surprise to the patient, right? They've come in with a heart attack or they're presenting with chest pain, so it's not an elective situation that you can prepare yourself well for. Obviously, patients in better shape do better through surgery, but before surgery, obviously, if you can stop smoking, stop any of your blood thinners, those things prepare you well for surgery, but most of these patients don't have that opportunity, unfortunately. Right. Things that patients will undergo before surgery, kind of in anticipation of it or potentially leading up to it, is most patients will have what we call an angioplasty, or an angiography, or coronary angiography. And that's where a doctor will go up and inject dye into their heart arteries to see which arteries are blocked or if they're critically blocked.
Kind of mapping it.
Exactly. It gives us a roadmap. And that's when decisions are made whether a stent or angioplasty would be of benefit. If there's only one vessel blocked in one particular spot, then they can intervene at the same time. Otherwise, if they can't and they need bypass, then they're taken from the catheterization lab where that occurs to the operating room. Not necessarily immediately, but they can go from one to the other.
Carotids, I mean, do we want to pre-op them in terms of to make sure that there's no, circulation problems?
Routinely, if I have time, what I will check before somebody undergoes bypass surgery, depending upon their age and their risk factor profile, if they're a diabetic, we check their hemoglobin A1C to see how well their sugars have been controlled. Why do we do that? Patients whose hemoglobin A1C is over 7 going into the operating room have a higher incidence of infection in their sternum or in the breastbone where we operate. So we always like to have an idea of how well their diabetes is regulated. We routinely screen for carotid artery disease, and that actually came from data that said if the left main artery has a blockage in it that's significant, there's a 10% incidence of carotid obstructions in those patients. A lot of people have extrapolated that to now thinking they should get screened for it. I don't know if it's really warranted, but it's a non-invasive test. It's an ultrasound test looking at the arteries in the neck, looking for blockage. And quite frankly, I think it's a reasonable thing to do in patients. It really is not very costly. It doesn't harm them at all. And if you're screening for blood vessel disease in somebody who you already know has blood vessel disease, hopefully you can prevent a stroke or complications from that occurring. So I do routinely order that in my patients. And if they happen to have a history of smoking or are current smokers, I look at their lung functions. Not that that's going to change my mind about what I do, but it does help predict how well they'll do around the time of surgery and if they may be on the breathing machine for a while afterwards.
Exactly. There were some studies that I actually came across in reference to stress management, post-op. People who actually entered into cardiac rehab programs after surgery, stress management, did better, actually had a decreased. Can you confirm that? Is that something that you see in your practice?
It's definitely confirmed. And I will tell you there are the kind of the gray zones in heart surgery, and surgeons tend to be pretty tough people, so we don't like talking about the touchy-feely side of medicine. But there's a very high risk of depression associated with bypass surgery. And those patients actually do worse. And so then you have to say, well, hey, there's really something to this. And I think there is. Stress management, I think, plays a huge role in this. Obviously, people who are not under stress and not under duress tend to be happier, have a freer lifestyle, and are able to live life a little bit more fully. And I think that's going to impact on their recovery from any procedure or surgery. Same thing with depression. And so, in patients that have a history of clinical depression, even before I operate on them, I discuss it with them, warn them about it, and I'm actually pretty quick to put them on an antidepressant after surgery if I think they need it. Now, part of that for me is I'm married to a psychiatrist, so I get beaten over the head with this, but it's true, and I think it's real, and it does impact on how well they do. And depression is a known risk factor for heart disease. People with a history of clinical depression should be screened a bit more aggressively for it.
See, that's good. I absolutely believe that. I think meditation, prayer, all of that has a lot to do with the healing potential in the body.
Anything that's going to make somebody feel better on a psychological level is going to make them recover and have a better sense of self after any kind of surgery.
Right.
I think the two things really do run hand in hand.
Yeah, that's great. Joe, you have a question there.
I do. Leaf, a female from Grand Rapids, Michigan. Would you say that you notice a big difference in the vein or artery quality from patients that eat a lot of red meat? I have a lot of veins collapse on a daily basis. I've been told it's from all the red meat that I eat.
I can't really respond to that. I'm not sure. First of all, veins and arteries are different blood vessels in your body, so I'm not sure what you mean by your veins are collapsing every day. Typically, people who have a diet enriched in high red meat and animal proteins tend to have more cholesterol plaque buildup in their arteries. But that's the arteries, not the veins.
Right.
So it's a little bit hard for me to assess what exactly you're asking. But clearly a diet rich in meat and animal proteins is probably not the best diet that you can choose. Certainly on occasion or a rare occasion, it's not a bad thing, but I wouldn't make that up as my primary source of protein.
Right. That goes to talking about olives. We had the olive meal here not long ago, and there's a protective effect. Olive oil is good for the heart. Is that something that you
that's absolutely
advocate?
true. Yep, I advocate for it, and I have my little spray bottle of olive oil by the stove, and that's what I use.
See, there you go. Joe, that's
I love
what you've been doing.
A month now, we switched from eating any butter at all to just olive oil, even on bread, toast, cooking with it.
It tastes good, right?
And I'll tell you
good.
what, I'm losing weight. I've noticed a difference in energy levels. My wife feels better. It's been fantastic.
That's good. What else, Joe?
Marilee Marshall from Knoxville, Tennessee. How would you say drinking alcohol on a daily basis ties into heart disease? I drink about the equivalent of a 12-pack of beer a day or 8 to 15 rum and cokes a day.
So that's a lot of alcohol. The American Heart Association will advocate for 1 glass of wine a day, and in particular red wine, because there's some protective effects of red wine, so white wine doesn't have the same benefit. But drinking an 18-pack of beer or multiple mixed drinks a day is really bad for you. Number one, in terms of carbohydrate intake, but two, bordering on almost being addicted to alcohol, and you need to watch that.
Right. It weakens the heart muscle as well.
It does. Alcoholism is associated with something called dilated cardiomyopathy, where your heart actually just stretches out for no real reason, and those patients do very poorly.
Yeah. So, I would definitely steer away from that amount of alcohol. Joe, do you have anything else there? We're going to just talk about some statistics because, people out there listening, there's some statistics that Dr. Smolens is going to share with us that it's amazing when you hear. We think that breast cancer is like the big buzzword, right? As females, that's kind of where our mindset is. But it can't compare to the cardiovascular risk.
Well, and here's the thing, and I've spent a lot of time looking at this and talking about it. So a lot of women are more fearful of breast cancer than heart disease if you ask them. And I think there's a variety of reasons to explain this. Number one, the American Cancer Society has done a phenomenal job of educating us about breast cancer. Everything's pink, go pink, get rid of breast cancer. Fantastic. Breast cancer can affect people at a younger age, so it tends to be a bit more tragic, I think, when it presents. But the fact is, heart disease is the #1 killer of women in this country. It's the #1 killer of men. The number of deaths from heart disease a year exceed the number of deaths from all cancer causes combined. So that's breast cancer, that's stomach cancer, that's any kind of blood-related cancers, colon, lung, everything combined. It is the #1 killer in volume. It does tend to affect people a little bit later in life. So I think the misperception is that we think, oh, it's not going to affect me till I'm grandma's age. It's okay, I'll die of old age and heart disease then. But that's not true. We have a number of people now presenting at very young ages that I'm doing bypasses on, younger than myself. And I realize as I get older, that number becomes more and more, but that's not even the point. I mean, I'm operating on people in their 30s and even in their 20s with blocked arteries. And I think that really comes from the obesity epidemic that we're seeing in this country, that then goes hand in hand with the diabetes, and then goes hand in hand with development of heart disease. And I think we need to do something to educate everybody out there to get a bit healthier. And if you just watch what you're eating, lose weight, watch your cholesterol and your blood pressure, if you're a diabetic, monitor your sugars, and stop smoking, you will do a tremendous amount to help yourself. And actually, that grouping of those 7 things that I just kind of rattled off is the American Heart Association's Life Simple 7. If you go to the American Heart Association website, you can see that. And it's all about lifestyle modifications. And quite frankly, it's common sense, and it's what I think we all know, but have trouble implementing in our daily lives.
Movement is medicine. Get up and
get up and move. The American Heart Association recommends 30 minutes of walking 5 to 7 days a week. I can't stress that enough. It's hard to do, but just get yourself doing it. Stop smoking, and lose weight. In Arizona, 55% of people who live in Arizona are overweight or obese.
Wow. And Arizona is active. It's
right.
not like
we're in a place where people can get out and walk around and do things, and we're all fat. So
exactly.
We need to do something.
Right. 1 in 3. What was it? Every 25 seconds, somebody is dying of a heart attack?
The statistics in this country are every 25 seconds somebody's dying of a heart attack, and every minute a woman dies of a heart attack in this country. So for the hour that we're here chatting today, 60 women somewhere in this country have died from heart disease.
How about that? That really, really puts it into perspective. Wow.
I call those my scared straight statistics, but they're real. These are real numbers, and they're striking and they're scary.
I want to just kind of talk about the atypical presentation, because if we can just get down to how people present, the textbook presentation for men coming in, crushing chest pain. In women, it's different.
Well, that whole crushing chest pain, left-sided pain, jaw pain is actually true, not even just for men, but it's really Caucasian men. African American and Hispanic men present differently as well, and women present differently. And women can present with fevers, chills, just feeling poorly, shortness of breath, increasing fatigue. And one of the more famous papers that came out probably about 10 years ago, looking at women that presented with heart attacks, documented heart attacks, their most common presenting complaint was nausea and vomiting and flu-like symptoms. So you could be sitting at home thinking you have a flu bug and actually having problems with your heart. And that's actually probably why women present later in their disease process than men, because who runs to the doctor every time you just feel kind of lousy? You don't, right?
You don't.
Why would you? And some women actually could be at home having heart problems and not even realize it.
That's interesting. Joe?
I'll start with the some questions up here in the chat. LDL 119, HDL 64, healthy diet and rigorous exercise. Should I be concerned?
No, you shouldn't. Those are good numbers, depending upon your age and your risk factor profile, though, and those that would be more data. But the fact that your LDL is less than 120, which is for people who are at reasonable risk, is good, and your HDL is a good number. You're doing fine. 51.
He said also, I'm 51 years old. Don't smoke and drink very little, maybe 2 drinks per week.
You're doing fine. Keep doing what you're doing.
Next question, Carmel Bay. Any thoughts on the high-protein shakes related to artery problems? How much protein is considered too much?
That's a great question, and I actually don't know the specific answer to it. It depends upon, a lot of these protein shakes use different types of proteins, and some of the animal proteins are really bad for you, and some of the non-animal derived proteins are actually good, and it would depend upon the type of protein constituents that they're using. But again, a lot of these supplements you have to really be careful about and watch what you're eating and consuming, because some of them throw in different chemicals and things that are really bad for you.
We have Rita from Chandler, Arizona, says, I have constant anemia. Does this make me at a higher risk for heart attacks? I eat a lot of liver, but it doesn't seem to help.
I would want to know, what is the cause of the anemia? Is it iron deficient? Are you losing blood? When I think of anemia, I think of either there's not enough iron, to manufacture blood cells, or you're losing it. So, is there a problem in the bone marrow where you're not manufacturing it? Is there a slow GI bleed? I mean, so those are the things that I would want to know to uncover why the anemia. Do you have heavy periods? I mean, those are the kind of things that we would want to know. The correlation between the increase in coronary artery disease and anemia, I'm not sure. I think symptomatically you can present with...
Right. I was going to say, it's not so much that anemia leads to heart disease, but if you have severe anemia and underlying heart disease, the severe anemia or the acute bleeding episode that can lead to acute blood loss can actually trigger a heart attack. And really what a heart attack is lack of good blood supply to the heart muscle, and then it loses its blood supply completely in a heart attack, and then the muscle dies. And if you have blockages that are critical and your blood count goes down, you can't deliver good oxygen and nutrients to your heart muscle, and it can trigger a heart attack. And in fact, probably once every couple of months I'll see somebody come in with GI bleeding, an ulcer or something causing some bleeding. They lose a fair bit of blood acutely, and they have underlying undetected or unknown heart disease, and they present with a heart attack.
It's interesting because I recently had a guy in his 80s who came in with a hemoglobin of like 5. I mean, it was very, very low. And he did fine. His cardiovascular status was fine. And that was really a good stress test for him, that he probably has good, good coronary arteries.
That actually tells you a lot about how they're doing, because if they can tolerate that without a problem, they are actually doing pretty well.
Exactly.
Jeanette Fuller from Phoenix. I drink about 3 pots of coffee a day. Is this a problem?
That's a great question.
I think anything in excess is probably not good for you, and caffeine in that much volume is probably not good for you. It's not good for your heart. It will increase your heart rate. It can give you the jitters kind of on the clinical side of things, but by pushing your heart rate up by the excess caffeine is probably not a good stressor for your heart. And 3 pots of coffee is probably a bit much.
Right. I mean, the vasoconstriction, the blood pressure. There's some studies out now looking at caffeine not being a bad thing, for Alzheimer's dementia, but all in moderation, I think, is really...
Well, I think, and I give these talks a lot, but I think everything in moderation is probably the key to life. When people go on these crazy diets and they go, I can't eat any protein or I can't eat any carbs. Well, first of all, you're never going to adhere to that for the rest of your life. That's insanity.
Exactly.
And so then you feel bad and you get this sense of, poor sense of self when you break the diet, and it's really bad. And so I actually tell my patients, if you really like red meat, I'm not going to tell you to not eat red meat, but make it that meal that's kind of for a special occasion. Make that burger and fries the one thing you do for your birthday each year, so that you get that flavor, you get that taste, you enjoy it, but it's not part of your daily routine.
It's funny, Jeanette Fuller from Phoenix said, don't tell the doc because I'm just concerned about the coffee. She said, but I eat so much chocolate. But she says, but it's okay because I'm very thin and in good shape. But I love C's candies. But don't tell the doc.
Well, make sure that it's dark. Make sure it's
right,
dark chocolate.
It's got to be the dark chocolate.
Exactly.
Dark chocolate's good for you. The higher the cacao portion of it is for you, the better it is for you. So if it's dark chocolate, it's good chocolate.
Right. The antioxidants. That's not bad. How about the Red Bull and some of these energy drinks? I'm absolutely against that stuff. And I don't know if what you tell your patients, but
yeah. First of all, I don't think they're good for you, and anything that's like truly super up caffeine in a can, I can't imagine is good for you. But then you have college students who need to stay awake for an all-nighter, and what are they going to do?
It's true.
That's probably better than some alternatives are for them.
That's true. Good. Okay, so we have let's talk about pregnancy, preeclampsia, some of the risk factors for coronary artery disease. Do you want to kind of speak to that for a moment?
Yeah, for sure. That's actually a newer topic, and I think is an important one. So one of the things that we've learned in the last couple of years is that there are different risk factors in women than men for heart disease, and preeclampsia has actually been labeled one. And so what's preeclampsia? It's high blood pressure during pregnancy, essentially. And it's actually a marker for those women that may develop heart disease down the road. It does not mean that when you're preeclamptic with your pregnancy that you actually have heart disease, but those women have a higher incidence of developing heart disease down the road, 5 to 10 to 15 years after their pregnancy. So what's recommended now is those women get referred for closer follow-up, closer monitoring of their blood pressure, cholesterol, and risk factor profile, and those women should be treated a bit more aggressively because we know that they are considered at high risk, or it's a risk factor for developing heart disease.
So it's kind of a hint.
Yeah, absolutely.
Yeah, it gives you a little hint into possibly the future. You can risk stratify. So that's good. autoimmune disease, we were talking about that as well.
Lupus and rheumatoid arthritis also fall on that list. It doesn't mean that when you present with your lupus that you have heart disease, but it's a flag that should be kind of raised, and knowing that it puts you at a higher risk for it. And these things came out of the recent American Heart Association's prevention guidelines, actually, for women with heart disease, that we recognize these two new categories as putting people at higher risk for heart disease.
You know, I don't think we think about that enough, that rheumatoid arthritis. We see it.
Yeah, we don't.
But we don't connect it necessarily to the higher incidence and risk of coronary artery disease.
Yeah, and again, nobody really knows what the risk is. And, you know, it's interesting because I'm not sure if it's actually the rheumatoid arthritis or some of the medicines that people are on to treat the rheumatoid arthritis. But those patients really do have a more aggressive form of the disease, and actually our treatment modalities are harder to implement in people that are that sick.
Right, that's true, yeah. It might be the inflammatory factors that are,
and inflammation is thought to be a big part of developing coronary artery disease, and that's why some of the treatments for coronary artery disease, including statins, are thought to help people. And, you know, even though people think of statins as lowering the cholesterol or total cholesterol, people with heart disease who've had bypass surgery in particular or stents are put on a statin regardless of what their cholesterol is because it has anti-inflammatory properties. And we actually now even screen with some lab tests for inflammatory markers, in particular in women, as a sign of early development or kind of a precursor to heart disease.
Right. I think I want to really echo what you said in terms of, you know, statins have much more benefit than just lowering cholesterol. You know, there's the antiplatelet effect and the anti-inflammatory effect. And so those of you listening, I think, you know, we've had people call in and ask that question. And I think it's really important to hear that from, you know, a cardiovascular surgeon. And this is really what the data shows now.
Well, you know, and it's interesting. I mean, patients always ask me when they leave the hospital, am I going to be on these meds my whole life?
Good
and there's
question.
actually a recipe that we send patients home with after heart attack or heart surgery. And that recipe or that concoction includes statins if they can tolerate them. Some people can't, and you have to check with your doctor. An aspirin, and it only has to be a baby aspirin. You don't need full-strength aspirin. And actually, recently, some of the data has shown that full-strength aspirin can actually be deleterious from a bleeding standpoint, so baby aspirin's adequate. And then we put people on 2 blood pressure types of medicines, one category called beta blockers, and they actually help relax the heart, and then ACE inhibitors, also a blood pressure-lowering drug, but that actually relaxes the blood vessels, so it decreases the resistance bed. And both those things help relax the heart muscle. So even though you may not have high blood pressure or high cholesterol, in these settings where you're at high risk for recurrence of heart disease, these drugs are actually very protective for your heart.
Right. You know, there's something called white coat syndrome. We see that. People come in, they get their blood pressure checked, you see your doc, and your blood pressure goes up. I think in somebody that has a history of coronary artery disease that has that, you know, up and down effect with their blood pressure, it's probably a good idea to control that.
Oh,
Even
absolutely.
though they say, well, at home, when I check it, it's fine. It's still spiking, and I think that's important.
I think that's very important. And the incidence of high blood pressure rises as we get older. Most folks, as they age, actually have an element of high blood pressure, and it should be regulated. And, you know, one of the things that came out of our recent guidelines, too, is that we used to think blood pressure was normal if it was 120/80. And actually, that is considered now the upper limits of what we consider normal. So a blood pressure of 120/80 is no longer great. It's actually a number that we have to kind of go, we better watch you a little bit more closely. So some of the numbers that we used to think are actually not even the numbers we use anymore. And people who have blood pressures of 140/90 are actually high blood pressure patients and should be treated for that.
Absolutely. It's the silent killer. Joe, you have some questions there.
We have a hi from Linda, Sue, Beth, and Henry in Pembroke Pines, Florida, and they say, thanks for what you do. We watch every week, and we love DocTalk.
All right.
Then we have Julie from Pomona, California. Does fasting hurt? I've been getting chest pains recently. Does fasting hurt the heart? I fast 1 week per month for religious reasons.
Well, it depends upon what your fast is consisting of.
They're just water fast, she said.
For the whole week or just
whole
during
week.
the day and then eating a real meat at night?
A whole week.
Yeah, that's probably not good for you. Whether it affects your heart adversely or not, I can't even really speak, but doing anything that dramatic is probably not the best thing for you. And if you've been having some chest discomfort, you need to be seen and evaluated by somebody. Get into your primary care physician's office, or if you're having acute issues, please go into an urgent care because you may be having a sign of something going on.
Right. There may be some deficiencies in, you know, different vitamins and so forth. So I would be very, very cautious. Let's talk about valvular heart disease for a moment. mitral valve prolapse? I mean,
so good question. So we've been talking about right now really blood vessel disease or coronary artery disease, and the two things are actually very different. And a lot of the risk factors that people associate with coronary disease, I get asked, is this the same risk factor for mitral valve disease? Absolutely not. And when we talk about valvular heart disease, there are very different issues. The two main valves, well, actually three main valves that we talk about in relation to the heart are the mitral valve, the aortic valve, and the tricuspid valve. There's a fourth valve called the pulmonic valve, and it's kind of the forgotten evil sister, but it exists as well. And so then there are different diseases that can affect the valves. First and foremost, you can have rheumatic heart disease as a child. It doesn't happen anywhere near as high frequency today amongst our kids as it did when my parents were children. But that can affect both the aortic and mitral valve, and it can cause them to become very stiff or immobile and may need to have valvular surgery to replace those valves. There's mitral valve prolapse, which affects a huge volume of people in the U.S., but only about 15% of the 15% of the population that has mitral valve prolapse actually goes on to need something surgically done to their valve. And so what's mitral valve prolapse? It's almost excess tissue of your valve, and so the leaflets become floppy, and that's actually one of its common names, floppy valve disease. And what can happen over time is the leaflets become so floppy and redundant that they leak, or the cords, the structures that kind of hold the leaflet intact and help line them up when the heart squeezes and the valves align, can rupture or tear. And when that happens, the leaflet becomes incompetent and you get a leaky valve. In those patients, really there's no medication or lifestyle modification that's going to change that. And you want to intervene sooner than later. And actually the data really supports intervening sooner, because if you allow your heart function to deteriorate from the leaky valve, you do worse with surgery and your life expectancy is limited. Whereas if we intervene when your heart function is normal, you should actually have an absolutely 100% normal lifespan. And those valves can actually be fixed as opposed to even being replaced.
Right. I know that there's some recommendation for SBE prophylaxis, for subacute bacterial endocarditis prophylaxis. And I know that there's some newer recommendations
they
out.
keep changing, and it's actually interesting because they used to recommend for people with mitral valve prolapse, not necessarily a leaky valve, but mitral valve prolapse, antibiotic treatment before any kind of dental or invasive procedure. They've actually recanted that. If you have mitral valve prolapse but not a leaky valve, you don't need antibiotic prophylaxis. Those patients are still at slightly higher risk of developing endocarditis. So then you say, well, why take away the prophylaxis? Well, my uncle, who is a dentist, explained this to me, and what they found was giving prophylactic antibiotics to such a large number of people led to complications from the antibiotics, and that rate was higher than those patients affected by endocarditis, so they took those recommendations away. They're kind of constantly in flux as to what they recommend and what they change. And so the American Dental Association has really taken the lead on that prophylaxis. But if you ever have mitral valve surgery, if your valves leak or you know that you have a valvular problem, you should get antibiotic coverage for dental work, colonoscopies, any type of surgical procedure, because that valve is really at risk for developing endocarditis or an infection of the valve, and that can unfortunately become a fatal process.
For those of you listening, I got to tell you, you're awesome. I mean, it's great to just hear, your way of explaining cardiovascular disease. So really, I want you to give our listeners just your contact information. I mean, where you're located.
Sure. So I practice out of Chandler area. I am in cardiothoracic practice with Red Mountain Cardiothoracic Surgeons. I have a partner, and we practice in this area. We do both cardiac and thoracic and peripheral vascular surgery, and our contact number is 480-782-6900.
Excellent. Thoracic, right now we have a patient not long ago with recurrent pleural effusions. And can you speak to that? I mean, in terms of
for sure.
the procedure that a cardiovascular surgeon, instead of going in and draining it and continuing to drain it, what can be done surgically in terms of preventing that fluid from building up?
Well, first of all, what a pleural effusion is fluid that accumulates around the lung, not in the lung, but around the lung. And there are a whole variety of reasons that can occur. Anything ranging from heart failure, so patients with a bad heart pump can actually develop fluid around their lungs, to infections. In Arizona, we have the lovely treat of dealing with valley fever, and that's a fairly common cause here. But people even with a pneumonia, a regular bacterial pneumonia, can develop it. People with tuberculosis can develop it. And then, unfortunately, cancer patients can develop what we call pleural effusions as well. Breast cancer patients that have had the breast cancer spreading to their chest, or lung cancer patients are the two most common that we see. And so then there are a variety of treatments that you can implement for that fluid. And first and foremost, you need to try to figure out why the fluid occurred. So a lot of times you'll get referred for a drainage procedure, just a needle stuck in the chest, aspirate the fluid out, check it for culture, look for bacteria, look at its chemical content to see what it's related to. And that should give us a clue as to what it's there for. And then if it recurs or we're not able to drain it all out, then there are a variety of interventions that we can do. Putting in a formal chest tube or a larger bore tube than a needle to try to drain it out if it's all liquid. And unfortunately, sometimes what occurs is in infection in particular, it becomes more gelatinousy than fluid-like. And so no matter what you stick in the chest, tube drainage-wise or needle-wise, it's not going to drain out. And sometimes you need a surgical procedure to clean it out. And a lot of times we can go in just using a telescope. It's called a VATS, V-A-T-S procedure, but it's a scope. We go in, make a couple of little small holes on the chest, and we can go in and clean out that debris and get the lung to re-expand to get rid of the infection or the problem causing that. And then in cancer patients or patients that have these recurrent collections, we can even instill a chemical at some point to help create scar between the lung and the chest wall to eliminate the risk of that fluid from recurring.
So that's where the talc, I mean, if you were to use...
Yep, we use talc. It's actually sterile talcum powder.
Yeah, that's interesting. Joe, you have some...
Yes. Let's see here. We'll start with, are there symptoms for mitral valve prolapse? It is diagnosed only with electrocardiogram. At what age should people have a baseline echocardiogram?
Okay, so it's not diagnosed with electrocardiogram. It is diagnosed either by auscultation with a stethoscope, sometimes you can hear an extra sound, or an echocardiogram, which is an ultrasound test of the heart. We don't routinely screen for it because there is no reason to routinely screen for it. And quite frankly, at this point, really most people with mitral valve prolapse won't even have symptoms, although some people complain of headache or jitteriness, and it can precipitate some abnormal heart rhythms, so some people can feel their heart racing or fluttering. And those complaints should actually trigger a workup by their own physician, not necessarily an echocardiogram, but it may include an echocardiogram.
All right. Rondé from Savannah, Georgia. I'm on Lasix. Is it still safe to have a couple of drinks a day?
Yes and no. Again, it kind of goes back to what we said earlier in terms of quantity of alcohol that you're consuming in a day. The American Heart Association recommends maybe 1 glass of red wine a day. If you're already on Lasix, it depends upon what you're on the Lasix for. If it's related to your heart, can also be given to you if you have liver problems. And if you're certainly having liver problems, you don't really want to be taking in or consuming alcohol every day.
All right. Marge Pergolis, Dayton, Ohio. My grandma is 83 and not in the best shape. Is it safe or not to have heart surgery on someone of this age?
Yeah, that is a great question.
It is a good question.
And I will tell you that I've operated on people in their 90s for open heart surgery. I am much more skeptical of the patients over the age of 80. And by that I mean I look at them a little bit more carefully and a little bit more closely because things have to be perfect. But 83-year-olds do very well with heart surgery if there's something that we know we can go in and actually reverse or fix. And in particular, valvular heart disease and even bypass surgery does really well in 83-year-olds. But the caution that I will tell you is, at 83, you've already lived your average life expectancy. I will never tell a patient in their 80s that I'm going to make them live longer with open heart surgery because that's a lie. They've already exceeded their average life expectancy. So at that point, what you're doing it for is quality of life. And by that I mean, if you can't enjoy life and it's your heart causing your problems, you really want to consider what you're willing to go through and what risks you're willing to take to reverse that. And open heart surgery in an 83-year-old is a perfectly acceptable practice, bearing in mind that it's going to take them a couple of months to recover. But if they're in pretty good shape going into it and they're really motivated, they're going to do okay.
You know, that brings me to post-operatively, we get these people up and moving within a day. I mean...
Oh, they have to be.
Right.
You know, one of the biggest risk factors after any surgery is blood clots in their legs, although it's slightly less after open heart surgery, and pneumonia. And especially, you can imagine some of our older patients that already are a little debilitated. If we let them sit around in bed, they will for sure get a pneumonia, maybe even get bed sores and complications, and then actually die, not from the surgery, but its complications. The sooner we get people up and moving, the better they do. So I tell patients, you know what, you're not going to want to do it, but right after surgery, we're going to be getting you up out of bed as soon as you're awake and breathing on your own. And most patients are ready for it because they've been prepared for it and know that that's going to be involved in their recovery.
That's great. I mean, it's amazing when you think about operating on 85-year-olds and see them up out of bed that night, the next day, out of the hospital for 4 or 5 days. I mean, it's amazing.
I will tell you something. The thing that I've really learned to appreciate as a surgeon is that an 80-year-old's body has been around for 80 years, and it's been worn and torn for 80 years. But there are 80-year-olds that are much better protoplasm than 50-year-olds. And it really depends upon mindset, how well they've taken care of themselves, level of obesity, and other risk factors. And I've operated on some elderly patients that I wish I could clone and operate on them every day because they do better than a lot of my younger patients.
Yeah, that's really, really, really great. So do you believe we only have like 10 minutes left?
The time flies.
It really, really does. This has been really great. Your way of talking and explaining is awesome, and I'm sure that our listeners are enjoying it. Is there anything else you want to kind of wrap up with or talk about, in the last 10 minutes or so?
What are some of the things that I always like to talk about? Well, I can't end this conversation without emphasizing that heart disease is the #1 killer. And I know I mentioned it earlier in the talk, but I have to say it about 15 more times because if nothing more, I feel like that is my goal to achieve that learning for people because I think that propagates into the rest of their lives. And then really to re-emphasize lifestyle modification. And I think every one of us can benefit from that. Absolutely. I don't think there's anybody that lives a perfectly healthy lifestyle. Maybe a few people, but not everybody. And I think if we really focus on that, we're going to do our youth a big justice. One of the things that the American Heart Association is pushing for kind of the next decade by 2020 is reaching out to the younger folks and really educating younger people and modifying their lifestyles at a younger age to avoid the later complications. Right. And now we're seeing a generation of folks that are suffering from some of the bad habits that we instituted 15 to 20 years ago.
Right. I think for the first time in the history of our generation, the children are dying before their parents.
Yeah, and it's from obesity and diabetes, and I don't want to lay blame on any one thing, but I will tell you that this whole fast food generation that came about just after I was a young kid, where, we have these drive-thrus that are fat-laden foods that kids live on, my daughter included, loves her McDonald's, chicken nuggets, that we've given to our kids. And unfortunately, with the economy the way it is, we've made that more affordable than going into a grocery store to buy a good, healthy meal. Right. So we've kind of coupled that with this inactivity using video games. Now, and again, I don't want to lay blame on Nintendo or anything else. I mean, I think things in moderation are good and video games are fun. But when you have a generation of kids that are eating fat-laden foods, that are no longer going out in the street and running around and playing kickball or riding their bikes, but are sitting on their couches and using their thumbs, they're going to become obese. And we have to act as good role models for that generation. And I think we really have to kind of set aside those bad habits and really squelch them at this point, And I remember hearing a woman talk, and she said, potatoes get a bad rap because everybody thinks they're French fries. And I always laugh about that because, it's true. I mean, everything gets a bad rap because of one or two different things. But, a potato is just a potato. And I think really what we need to do is embrace kind of living a healthier lifestyle. You can eat a baked potato, you just don't have to fry it. You can play video games, but you don't have to play them for 5 hours a day.
That's great. Very, very good.
Couple last questions here. Tony, Fort Lauderdale. I have had 2 heart attacks. I now walk daily with the dog, and I occasionally get bad chest pains, but they go away. Can you over-exercise the heart?
You can't, but if you've already had 2 heart attacks and you are experiencing chest pain with your daily walks, you need to go back and be reevaluated because you could have an ongoing problem with your heart. You can't overdo it, but what you're doing is probably stressing your heart to the point where you're actually getting ischemia or lack of good blood supply to your heart muscle.
Right. So in general, I guess the question is, just for people out there listening, can you overdo it and hurt the heart in terms of, training for these marathons and these triathlons and all that stuff?
Again, probably the best answer to it is I think anything in excess is probably not great for you. Some of these triathletes are in incredible shape, and they take really good care of themselves, and they really do it properly. And I think that's reasonable, but you have to really watch what you're eating, monitor how much exercise you're doing. Can you overdo it with exercise? Probably not. But if you start taking supplements that are really not good supplements and you're working out excessively and taking steroids, for instance, that's not good for you.
Exactly.
And there are people that take it to extremes and do those things and take supplements that are available, and they think they're okay because they're available in a health food store, and they're upping levels of certain enzymes in their bloodstream that are really not healthy because they're at abnormal levels. That's not a good approach.
I think that's what we need to look at. Make sure you're hydrated. You know, if you're exercising, we see rhabdo a fair amount, and you know, rhabdomyolysis that we were talking about on the last show, where you know the muscle breaks down and it can cause a lot of problems with the kidneys and so forth. So in moderation and building it up. You know,
right, and you have
really,
to do it gradually.
Right.
I mean, you can't just go out and run a marathon or pretend you can or try to. And we're here in Arizona. I always tell people walk around with a bottle of water because you really don't forget that you're living in the middle of the desert.
Exactly.
But staying hydrated, doing an exercise program with some moderation and some monitoring, I think is a really important thing. And I will tell you, as you advance in age, before you go out and adopt an exercise program, make sure from your own physician, your primary care doc or a cardiologist if you're under cardiologist's care, that it's appropriate for you to go out and exercise. I don't want somebody to just go out and start exercising who hasn't been evaluated, who's obese and is trying to do something to make themselves better and precipitate a problem from occurring.
Absolutely.
And then the question of the day.
Okay.
Louis from Mesa is a vegan. Him and his wife are vegans. They do a lot of fresh juices on a daily basis. Do they need red meat or any type of meat to sustain?
They don't necessarily need red meat, but they need protein. And so as long as they're taking protein in some form, they're going to be fine.
Very good.
Doesn't need to be animal protein.
Okay.
Well, you know, this has been really, really great. Thank you so much for coming. And
Thanks for having
you know,
me. This is a blast. I love
sharing.
it. Thanks.
This is good. Next week, you know, we will be here. It'll be the day after Christmas. We'll have just an open question-answer session. If you haven't liked us on Facebook, please check it out. We have DocTalkRadio.com. You know, we'd love to be in contact with you. And until then, I hope you have a Merry Christmas and God bless. We'll talk to you later.
All right. Here is Doc Talk, and we will see you next week.
This concludes Doc Talk Radio with Dr. Ann Borik. Till next time, I wish you health, wellness, and many blessings.
Doc Talk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.